Hi everyone, it's Rajiv Ramchand. This is session 8 of our basic epidemiology series to help you understand the news that's coming in with respect to COVID-19. Today we're going to be talking about cohort studies, which is one of my favorite types of things to talk about with respect to epidemiology. I hope you enjoyed as much as and I hope that I do justice to the topic. It's really fun. So this is about how we start collecting that data to estimate things like risk and the relationship between exposures and the outcomes that we're interested in. And there's two ways that we can do it. One is the cohort study, which I'm going to be talking about today, where we say, and we can ask the question, among those exposed, who develops disease? And that's different from a case control study, which we'll be talking about next, which asks, among those with disease, who was exposed? So different questions, really subtle, but different ways for filling in the cells in this 2x2 contingency table. So let's talk about cohort studies and how we go about doing these studies. First, we enroll people, generally speaking, without the disease into the study. We then collect data on them. We collect demographic information. We want to know how to get in touch with them so we can contact them again. We want to collect data on some of the exposures that we hypothesized are related to the incidence of disease. And we also want to ask about health status. And we're going to ask this from them a repeated number of times. Maybe we ask it every day. Maybe we ask it every week, every month. We have some system in place where we're going to ask these questions again and where we can look and see whether disease develops at these follow-up assessments. And that's what our third step is. We essentially follow people over time to understand who develops the disease and who doesn't. So I didn't show all 5 of our population from our hypothetical example, but just in this group of 3, we see 2 people develop disease and 1 person didn't. Pretty simple, but actually much more complicated than you might think. What can we uniquely measure from cohort studies? What is so great about it? Do we have the ability to measure prevalence, which is the proportion of a population with an infection or disease, or the incidence, the proportion of the population that develops the disease or becomes infected? Remember from session 2, we talked about these two? Well, if you answer incidence, you're right. And that's why these studies are so helpful and so unique, is that we get this really clear estimate of the relationship between exposures and diseases. But we can also look at risk. And this is an example from one of my own studies that I conducted with my colleagues Andrew Morrell and Kirsten Becker at the RAND Corporation. And we collected data on 395 youth who were adjudicated and referred to group homes in Los Angeles. And we followed them for around 7 to 8 years. And in that group, 12 had died. So 1 out of 30, 3% of the group had died. And 7 of them had died from gunshot wounds. So we could estimate the risk in this case of mortality among those who were referred to group homes in Los Angeles, among those youth who were referred to group homes, which is actually a very sad outcome. And for those interested, you can look at that paper, but we also found that this risk was 500 times higher than youth of similar ages in Los Angeles at that time. The advantage of these cohort studies is that we have what we call temporality. We can, generally speaking, have really strong evidence that our exposures, whatever we hypothesize to be related to the disease outcome, occurred before the development of disease, because we're recruiting people without the disease at intake, asking about exposure, and then following up to see which of those exposures lead to increased risk of disease. Another example from my backyard, this was actually my dissertation, part of my dissertation, which I did at Johns Hopkins with my colleagues Nick Ialongo and Howard Chilcote, my advisors actually. And what we looked at were kids between the 10th and 11th grade who started to work for pay during high school versus those who didn't start to work for pay. And we looked at the relationship between starting to smoke. And so among those who did not start working, 4 started smoking in that time interval out of this group of 111. And so the incidence was 0.04. Among those who started to work, we saw 15 started to smoke, so the incidence was 0.29. We constructed relative risks, which we went over last session, and our estimate was was a relative risk of 8. So we could conclude that youth who started to work had 8 times the risk of starting to smoke relative to youth who did not start working at that time. There's one other type of study of a cohort design, and that's called a retrospective cohort study. And up till this point, we've been talking about that we recruit people without disease and we follow them over time, and then we see who develops disease. Well, sometimes we don't have that luxury, but we can still look at a population. So let's say a population admitted to a hospital. We figure out who had disease, but our information and our historical data on exposure comes from historical rosters. So data that the hospital was collecting perhaps beforehand, or just part of their routine duties. And then we apply the same analytic tools. We're just not necessarily taking the time or the years that might be necessary to look at exposure and to follow people over time. And I mention that because there's one study that it's kind of this other study called the case control, which we're going to be talking about later, but they apply this method that we've been talking about with respect to exposures and disease outcomes. So what they were interested is mothers who had COVID-19 pneumonia and the neonatal effect, so the effects on the babies that were born to these mothers relative to those who were born at the same time period without COVID-19. And this was an example from Wuhan. And they had 17 babies born to those without COVID-19 and 121 born to negative mothers. And what you'll see, mothers who didn't have COVID-19, and what you'll see is that those who were born to babies with COVID-19 positive mothers, there was a higher rate, 17.6% versus 2.5% of being low birth weight. Premature birth was also higher in the COVID-19 positive group, but there were no differences. Even though this percentage is greater, they did a statistical test, and there were no differences in this intrauterine fetal distress. They looked at a number of other outcomes. These are just the ones that I'm sharing with you, and this is from March 30th. So a very interesting study that was, again, this retrospective cohort design where they could look back at their hospital records and see what pregnancy exposures, in this case COVID-19, predicted birth outcomes for children. This is, April 2020, we're 2 months into the epidemic of COVID-19. We haven't seen many of these cohort studies, especially those that compare outcomes between two groups, those with COVID or those who died versus those who didn't. What we're seeing primarily are case series where we're only looking at those with the disease and some descriptive epidemiology about them. There's some exposures, but generally speaking, it's descriptive epidemiology, and it's focused on those with the disease. And I don't want to say that that's a bad study design. It's actually quite informative. So this was a study that was published April 6th among Italians treated in ICUs. And you can see a lot of important information. The median age was 63, the majority were male, 49% had hypertension, almost all of them needed respiratory support. And when they closed the study, 26% had died, and then they looked a little bit at exposure and found that older patients had higher mortality. Again, a case series. What we would want to know is how does this compare perhaps to other people who were in the ICU, or how does this compare to people who did not enter the ICU? So it's informative, but it really hinders our ability to glean some insights into the relationship between exposure and disease. So that's it for cohort studies. I hope you found this helpful. I was glad to share some of my own personal research with you. Next session is our last session, case control studies, that I have planned at least. Until then, stay safe, stay healthy, and stay informed. Thanks.